Welcome everyone. This is our first clinical studies section, and thank you for attending. So we have a real privilege today. This is the first time we've done any clinical studies relative to eye surgery at all, so I'm kind of interested in following it. I'm Art Erdman, professor in mechanical engineering, also founding director of the Bakken Medical Devices Center. And I've had the privilege of working with Dr. Nazari for quite a while, and we have a great relationship. And I'll tell you that it's so important for engineering faculty, if you're doing innovation in medical devices, to have someone like Dr. Nazari to work with that will, at 7 o'clock in the morning or 8 o'clock in the morning, get on a Zoom call with the design team, you know, essentially every week. It's unique, and so he's taken out time to work with a number of the students. So a little bit of background. Dr. Nazari was a retinal surgeon in Iran, came to the U.S. and in 2010 was at USC, where he was essentially a kind of a postdoc, but also clinical faculty. Then in 2020, he received at University of Texas Medical Branch PhD in neuroscience, and during the same time he's doing a residency. And we were fortunate that he came here in 2019. So he treats patients simple and complex vitreoretinal issues such as macular degeneration, which is an interest of myself and a lot of my students. Diabetic retinal diseases, retinal detachment, retinal holes, inherent retinal disease, retinopathy, and many other things. So, you know, it's a great privilege to have someone who has a great interest in the development of new devices and is also, including today, doing surgeries and meeting with patients. So I'm going to, before I turn it over, it's a small group here, and I think we have someone with a mic. So if you have a question along the way, just yell out. I have a question, and this way we get the things that we're most interested in, so please do that. And so we'll turn the floor over to Dr. Nazari.
Yeah, thank you so much. Good evening, everyone. It's an honor and pleasure to be here, to be in between engineers, not knowing a lot about what you do. However, we use your products literally every minute, every hour on our clinic and operating rooms. So I'm gonna just give you an overview of what I do as a clinician and what gaps I see in my field. You know, I wish this was a little bit better, or I wish this machine did things a little bit differently. So I'm hoping that it is going to be interesting. So as surgeons, you would expect that we do a lot. Surgeons work with a lot of blood and flesh and things like that, but we are not that type of surgeon. So I'm going to show you a little bit of blood, but not much. But feel free, as Professor Erdman said, just stop me and ask questions if things are not clear. So my title is Diving into Deep Dark Vitreoretinal Ocean, and there is a reason for deep ocean of vitreoretina. I'm going to get back to that. So we'll start with the basics. So eye anatomy, of course, we are going to talk about eyes. If you look here, so this cornea, front part of the eye, clear structure like a window to the eye. So behind that, we have iris, the colored part of the eye. So you see here. So we dilate it to do our examinations and taking pictures and imaging studies. Then we have this adjustable type of lens that as we age becomes cloudy. It's called cataract. Then this space is called vitreous cavity. So it's just hollow space filled with a jelly-like liquid. It's called vitreous. So when we do surgery, we have to pass. And then the retina and other supporting layers underneath. So when we do surgeries here, I'm going to show a lot of those to you. So we have to pass through this vitreous. We have to remove it. And there are some diseases that involve vitreous. So in the eye, so this is a busy slide, picture, but I'm going to just go through part of it. This is how we see, right? So we have a clear medium like a camera, just a classic type of analogy for the eye. A camera that reflects images outside in the world are reflected or are reflected on retina, back part of the eye, and then visual signals are transferred by optic nerve to midbrain and then to visual cortex, which is in the back part of the eye, back part of the brain. In the eye, we have retina as, so very often I describe it to our patients like a wallpaper that just sort of covers inside the room. So we have this wallpaper, and thanks to its neuronal elements, cones and rods, photons or photonic energy is transferred to electrochemical and then and the visual neuronal signals that are transferred to brain as we talked. All right, so this is the environment I work in, and you know there are so many diseases. We are gonna look at just a few of those. Let's start with the just very benign. Many of us have seen that vitreous opacities and floaters. So you may say that yeah, I've seen these, and but as we age, you know, age 50, 60, 70. We are going to have more and more of these. So vision without floaters and flashes, so it's just like normal vision we have. But I want you to focus on this. You see just like a little bit of smudges in our visual field. So this is mild and normal. You know, as I said, all of us have that. But this could be these floaters or opacities. So these cobwebs or dots or strings are coming from vitreous opacities inside the vitreous cavity. If these opacities are denser and more opaque, then they are going to be problematic. So like this patient, so has a lot of floaters, then that's the time that we go and do surgery. So we have non-surgical options, but very often we do surgeries to remove these opacities, replace them with just saline, and then patient's problem resolved. So other diseases that can involve the cavity is hemorrhages. So if you have diabetes, you can bleed inside your vitreous cavity, and then of course that blocks you from seeing outside world, and for us, blocks our view to see your retina and then see what caused bleeding and treat those underlying causes. So again, so this is normal vision, and this is a patient who had vitreous hemorrhage down here at the bottom of their retina, but since everything is upside down, so that in real world, in your visual field, you see that blocking of visual field in top part of your visual field, and then clots and clumps of red blood cells blocks your view. So this is one of our patients, very, very severe. Probably, this is a recent patient. She can see world like this because of this clot of blood and then blood that is floating in front of retina. And this is, of course, more severe. And then sometimes they're so severe that we cannot see, and then we have to do surgery to remove them. For example, this patient was an engineer, actually, IT field engineer. As the diabetes, one eye was good, the other bled very densely in front of, the central part of retina, and then his vision dropped to hand motion or light perception only. That's when I went and did surgery, so his vision went back to 20/20 and complete normal vision. So a retinal membrane is another set of diseases. So when scar tissues, so we saw retina, that inner lining of the eye, that wallpaper. If we have something contractile on that inner wallpaper, then it can cause wrinkles on the wallpaper. And of course, how patients perceive it as wavy lines or dents on straight lines, or just world is just wavy and and not normal. And when we examine, these retinal membranes appear like this. So this is a membrane on top of retina. So image quality probably not good, but you can see that there are wrinkles on retina that makes vision abnormal. So this is another patient, again, fairly new patient, recent patient. So we were seeing her for a different reason, and this is just normal macula, a cross-section from retina from a few years ago. But then she recently came back with a macular hole. So you can get a hole at the center of your retina, and that's also a disease that I operate and we operate, and I will show you a cool, probably her surgery, how we fixed it. So this is how I examine, when I examine her, I see. So this round circle is the hole in retina. And this is how she sees the world. There's a black, and you can imagine how disturbing and, bad it is for someone who has this vision. And then this is her eye after surgery. You see that her retina went back almost to its normal anatomy. So retina detachments are another class of diseases that can cause, that will need surgery, laser or surgery. But anyway, so when we have a hole or defect in this wallpaper, fluid can pass through separate wallpaper from the wall, and that's when we lose, again, part of our visual field. And then since this hole happens, when the hole happens, we often have hemorrhages in the eye. As you see here, we have these smudges or floaters floating inside the eye. Okay, so those to the left and down should have come later. But anyway, so this is another recent patient, came with just very vague visual symptoms, but she had retinal detachment in both eyes. So this part and this part, both are detached. So I did laser for this eye, we did surgery, and she's doing okay now. So, but it could be, this is fairly subtle, but retinal detachment could be very obvious like this. So you see how retina is detached here, fluid went back under retina through this hole, and of course, vision loss. So retinal holes could be subtle and small, and they don't cause detachment. Or we can, if we catch them early, we can treat them with laser. So like this patient never progressed to retinal detachment. Or they can have a huge tear like this called giant retina tear. I also have another surgery video for that. These are two cases, the two patients with retina tear that got laser treatment, and Sarah knows. So we are trying to take pictures from these patients. And Dr. Ehrman, our other project is just to replicate these tears and to be able to examine those and treat laser those. So there are different types of retinal detachment. So those were from a hole, but if we have traction, something pulling on retina can tend retina up and detach retina. Like this patient came with both eyes, lost vision for one eye, left eye for years and years, but this eye recently, you see that this retina is separating from underlying layers. He also had surgeries, probably multiple surgeries, but then eventually he ended up okay. Now his vision is 20/40 and he's happy. So we are now gonna dive deep into the ocean of vitreoretina. So I said, we do surgery. So the name of surgery that we do is vitrectomy. And it used to be called deep vitrectomy. That's why deep comes. So we can do vitrectomy from the front part of vitreous cavity or deep entire vitreous, and that's how so we are going to talk about these surgeries. So this is how it is that these cartoons show what we do, and I have other. So in summary, we connect an infusion line to the eye, just brings saline in the eye, just preserve eye's shape and pressure. With another hole, we put a light source in the eye because we have to see this inside the eye. And then we have our vitrector, which is a hollow tube that cuts and sucks the jelly out of the eye, like how it is now. And then we we see this through a microscope, on top. Again, I'm going to show this to you. So this is a picture. So this is just surgeon's view. Infusion lines comes from one side. Light probe comes from the other side. Vitrectomy probe comes from the other side. This is a side view. Like we just saw that. What is vitrectomy probe, or what it does? So this is a vitrectomy probe. You see that there is an opening at the tip of the vitrectomy probe, but this is not hollow. So this is like almost double-barreled tubes inside each other, and then this oscillates, goes back and forth, and cuts, and then aspirates the fluid and jelly from the eye. So as you see, this is how it works. So this inner tube moves in, and there's a suction going on. Fluid gets pulled inside, and then if everything is fluid, we don't need this cutter, right? We can just aspirate everything. But vitreous is a jelly, and we cannot just suck that jelly up. We have to cut it and scoop it out. If you think about it, just tiny bit of scoops every single time to remove the vitreous. So this is how, just a cross-section to a vitrector. So it is operated pneumatically, so machine operates it pneumatically, that back and forth, and then, of course, this spring inside just reflexes back, and next time we have, again, another pushing forward and cutting and aspiration. So we have aspiration port, pneumatic drive, and pretty much it. So 2 tubes come to vitrector. And so we have different sizes of vitrector. So when I started my training years ago back in Iran, so everywhere in the world, it was 20-gauge vitrectomy. So these are nowadays. So if you look, you see this is a tiny needle, but it is huge, and it was huge at that time. But that's what everyone was operating on. But then we had 23, 25, 27-gauge vitrectors. So very often now for 25 and 27 vitrectomy, we don't even place sutures. We just go in, remove the vitreous, we do what treatments we need to do, and then come out without a stitch. So this is the vitrectomy machine, and there are multiple companies, but this is probably most commonly used in the US Alcon's Vitrector Constellation, Fort Worth, Dallas-based company. But there are other US and European companies or international companies making vitrectomy. I have a small video to show you how it works. And then this is the microscope, but we sit behind so the patient lays here, so these are vitrectors and light sources, and then this is a microscope, and we look through microscope and see. So you see everything is related to what you do. So, and I learned from Professor Erdmann a few months ago or last year that everything that is not updated in last 10 years, there got to be an update or improvement in that. We just need to find what updates we can make. And many of these, of course, many of them are updated, and companies have great innovation and improvement and development sectors, but still, ideas and improvements are probably, this is very cliche, but limitless. How much, it just all depends on how much we can imagine and how much we demand from you to improve our systems. So this is a video from internet, but I was told that I have to go back to this.
Welcome to the Constellation Vision System, a multifunction surgical system for use in anterior and posterior segment ophthalmic surgeries. The Constellation System posterior segment functions include 20, 23, and 25-gauge vitrectomy at 5,000 cuts per minute.
And now we have
Posterior
10,000
segment
and 20,000 cuts
using
per
the
minute.
latest xenon technology. Maintenance of a desired surgical intraocular pressure with IOP control. Proportional diathermy. Injection and extraction of viscous fluid. Proportional reflux. Automated fluid air exchange. single-person acquisition of gases used for intraocular tamponade, and lens fragmentation. In addition, the Constellation Vision System
No.
lens, including the Ozel handpiece technology, irrigation and aspiration, and anterior vitrectomy. The videos provided will demonstrate the setup of the
This is a
Constellation
nice
Vision
video.
System.
Shows how
These
vitrector
videos
tip
are not intended to be used as a replacement for
scoops
the
up
operator's
jelly.
manual or the directions for use.
All right, so this is our operating room setup. So I put a few videos, pictures and videos. Again, all technology. So every single piece and of work we do and every single part of operation is related to is facilitated or done by what you do. So this is how my ed sets up their tables. So vitrectomy machine. I took this video. I'm hoping that I can play it. So this is how we do. So this is so one of my students took this picture while I was doing the surgery. So this noise you hear is that zzz noise, what vitrectomy machine's noise. So you saw light pipe in one hand, vitrector in the other hand. Infusion comes to the eye. So we'll skip. Oh, okay. Anyways, probably that's all we need to know. Then I'm showing you different parts of the microscope and the room. But probably we can move forward. So I'm gonna now. So next hour or so is gonna be just going through vitrectomy surgeries for the diseases that we talked. So.
Sorry, this is a really dumb question, but when you
No question is dumb, so go ahead.
when you remove the vitreous humor, what do you replace it with, or how does the patient go on their way and see again?
That's not a dumb question. That's a question every single patient asks us. So yeah, that's a very good question. So vitreous, we really don't need it. So just it's garbage. No, we need it. So that was a joke. So it's a place for. So it's a clear fluid. So it's almost like a placeholder. So we can replace it with any clear fluid. So as you saw, many of the diseases that we talked, their origination starts from vitreous. So vitreous is not a great thing to have if it doesn't behave well. But when it doesn't, then we can easily remove it and replace it with saline, and body replaces it with its own fluid. So removing vitreous it doesn't have any negative effect in the eye. So we replace vitreous with saline. Sometimes we replace it with the oil, silicone oil, or different gases, as you saw in that YouTube video. And there are different purposes for any of these. But now that you asked, I want to mention this. So for a patent I have from USC work that I have is a device that we can put in the vitreous, and it releases oxygen. And you can, in ischemic strokes of the eye, so they don't get oxygen from the normal vasculature, but then you can release oxygen from vitreous cavity. Meaning that the reason I'm saying is that you can use vitreous and removal in your advantage. So for treating different diseases. So this is a big idea, $1 billion idea, whoever can do this. If you replace vitreous with a substance that releases medicine, so it can release medicine and then can treat diseases. Anyway, so no, not a problem. You can release it. You can remove it and replace it with saline, and body replaces it with its own fluid. So you saw that I placed the infusion port. So these are trocars, and I'm going to connect fluid into, so unfortunately, I don't see the sliding bar to advance this, and that's the problem I have. Let me see how we can skip areas that we don't need. So, yeah, patient is numb or anesthetized, so they don't feel that poke.
Yeah. We do, though.
Do you have a question? Yeah, I'm gonna let it play. So because.
All right. Oh, thank you. So I was wondering, when you're injecting the eye like that, what does the recovery process look like for the patient, and do they receive like any temporary loss of vision then following the procedure?
So it all depends on what kind of surgery they get. For example, for macular hole, it's almost immediate recovery. Having said that, we sometimes after macular hole, not sometimes, very often, we place a gas bubble inside the eye. Eye is good, but gas bubble just messes up with eye's optical properties. So images are not focused on retina as they should be. But then that gas is replaced with a fluid in the eye, in a matter of weeks, and then vision recovers. Okay. But then there are other diseases I'm going to show you. So I'm doing now vitrectomy. So we have to remove the vitreous to access retina and the macular hole to treat it. Yeah, so there are diseases that have longer recovery, of course. So now, after removing vitreous, I'm placing this dye. This is just a safe dye to use in the eye, trypan blue, to stain layers over retina. It's called ILM. Its contracture opens this macular hole. So I'm trying to stain ILM to be able to peel it. And then when we remove that contracture, then the macular hole closes. So now you see there is a bluish hue to retina surface in some areas. With a different type of microscope, not microscope, but different type of magnification and different types of lenses. So these are, so in some sense, vitrectomy, what we do is like endoscopic procedures, right? So we through a trocar, we go inside the eye, and as you see, this forceps opens and closes inside the eye, and my hand is outside. So I am grabbing, and if you think about this ILM is like 3-4 micron. When it becomes thicker, it becomes 5-6 micron thick. These are super thin layers. So trying to pinch it and just lift it, and then as you're going to see, I'm going to peel it. So small pieces of ILM. Gets stuck to my forceps tip. I clean them with my light source. I pride myself of being a fast surgeon. I don't do any extra movement and just do everything as quickly as possible. But this is the fastest it can get, because we are very close to retina, very vital organs in the eye. Just the slightest mistake, I can cause damage to retina. So don't get bored that this is slow. Why he's not moving.
Tell us again what layer you're pulling off.
I am pulling ILM, which is the innermost layer. We don't even see it here. So this is on retina surface.
Oh.
So.
And it's defective in some way?
It is defective, yes. That's also a layer that, so there is a big there was a big debate whether we need ILM or not. So of course, so it has a physiologic properties, but when it becomes defective, removing it doesn't cause any further problems. Now you see its rolled edges that is floating in the fluid is more bluish. So, okay, so I think I can move a little quick.
What does removing that layer have to do with the macular?
Hold for the mic, please.
Can you explain one more time what removing that layer has to do with the macular hole?
Yeah, so that's why we get macular hole, right? So that's the main question. So we have macular hole because this ILM contracts centrifugally. So it contracts centrifugally, and the central macula, that thin part, that dip here, is the thinnest or weakest part, but the most critical part for us to see, just the dead center of our vision. So we have with this centrifugal contraction from all over, then retina just pulls and opens the hole. When we remove it, retina's that elastic, tissue's elastic properties, it just brings the retina back to its place. Now you see I've removed it, I've peeled it, maybe I go back. So you see, this is how, now that I have an edge, a good edge, then it becomes easier and faster. And we just remove 2-3 millimeter diameter from around the fovea, that center part, and that's enough. Was there a question?
Is the patient under local or general anesthesia?
That's also a very good question. Both. It could be both. So, if a patient has a tremor, they cannot, has a restless leg or something that they cannot, or they have a severe cough, they cannot stay still. We do general anesthesia. But overall, local anesthesia is good and safer for patient, easier on their heart and lung and everything. But they need to, I warn them, I talk with them, during this. So I'm talking with patient most likely at this time. Just saying that, I'm close to your retina. I want you to stay still for the next few minutes or so.
So, but if they're not under general anesthesia, is their brain just seeing a very bright light with your light source inside?
That's also a very good question. So the way we numb the eye is that we inject numbing medicine behind the eye. So we call it retrobulbar, posterior to the eye, just behind the eyeball. That's also one of our gross things we do, stick a needle behind the eye. But anyways, that anesthetizes optic nerve also. So the pain gets anesthetized, you don't feel pain, but you don't see, and you cannot move your eye because muscles also get anesthetized. Anyway, so now with the wider field of view, with the lower magnification, you see that ILM was removed, and these are pieces of ILM floating. I'm going to remove them. And at the end, we replace the, I think in this surgery, so you're going to see that. So here I'm replacing fluid with air and then with gas. I don't want to go, so you see I'm aspirating fluid. If you think so. There is now a very thin layer of fluid at the back, but eye is filled with air now. But anyway, so I removed the trocar, and as you see, I didn't even place a stitch, so it is self-sealed, even though this is a 23 gauge, but it didn't leak. And that's pretty much it. Okay, so let's move to the other surgery. So this is very similar to that. But so now we don't have ILM contracture, but not just ILM contracture, but there's another layer on top of ILM, which we don't have that layer, so it's called epiretinal membrane. So we have this layer contracted. You see how distorted retina is. So you remember that view from CD, everything was wavy. Now this patient sees everything like wavy, it's just their life is ruined. So it's the same thing. You saw that I've placed trocars. We do vitrectomy, blue dye. So this looks very similar to the previous surgery, but trust me, this is different patient. So
What causes that extra layer?
so mostly, so as we age, vitreous jelly changes and separates from retina, called the PVD, posterior vitreous detachment, that causes floater we were just talking about. Sometimes remnants of vitreous jelly remains on retina. So if separation is not nice and clean, then jelly remnants on retina starts to contract. In essence, it's like a healing process or a scar formation process. But now this here, scar formation is not in our favor. We have to remove that scar. So very similar to what we did, but now it was a very much thicker layer.
May I ask, at what point do you know that there's this extra layer? Right away or upon just normal observation, or do you have to go in there and see?
You can have a membrane, but as long as, even if you have it, but you don't notice it, that's okay. So if you have it and it affects your vision, then you go, right?
No,
so you don't.
I'm asking, when do you find out?
Okay, so a patient comes and we, with symptoms, and we do this OCT picture, and we see, in examination we see,
Yeah.
but very subtle membranes we may not see, or if patient has cataract, it's hard to see, we cannot see, and then we do this. So I'm now staining for a second time, making sure that there is no membrane left here. But with the scan, we see that there is a membrane. But then again, if the patient has membrane but is not symptomatic, or saying that, hey doc, I'm 95 years old, I don't need to see very much details, I'm fine with what I have, then we don't have to do surgery for them. This is not one of the diseases that can make you blind. So unlike retinal detachment or other surgery, or other diseases that I'm going to show you. Any questions here?
You mentioned how this is probably the fastest you can perform this procedure, just with the risk of damaging the retina. What happens if you do happen to damage the retina? Is there, or how would you go about dealing with that?
It all depends on what happens, right? So just knowing how it is, so how damages happen, we are just extra cautious. It can happen, but it doesn't mean that it will happen. So for years and years, I've done this surgery safely. It could be different when we operate with our trainees. But very delicate parts like this, we don't even allow our fellows to do. We do it. So if, yes, someone is not careful, doesn't know how to do it, or doesn't, so patients sometimes, a patient wakes up, anesthesia doesn't give medicine, wakes up, that my forceps can, hit the retina, cause a retina tear, damage, things like that can happen. Those are bad stuff. So you see that I'm intentional. I never go over the central dead part. Just knowing that if something happens, 1 in a million, then our damages that is going to be caused is severe. Mm-hmm. But if damages is caused somewhere else, if patient really looks for it, can find the defect in their visual field. But often, again, they don't notice, somewhere here, just a small black spot. It can cause damage, but if they're not right at dead center, that's also probably tolerable. Okay. All right, so here I was looking at the peripheral part of retina to make sure, and this is, again, air going inside the eye. Okay. We are injecting antibiotic and steroid medicine. All right, so I just wanted to show you a few of my favorite forcepses here. So not the first one, but the second surgery was done with this forceps. Alcon introduced this maybe a few years ago, shark skin forceps. As you see, so these are super tiny. So the whole width is less than maybe 0.3 millimeter. but you see how detailed so pattern it has. Sort of, you go over retina, and then so it sort of grabs. It has just a gripping force that pinches ILM, and I can remove it safer and start peeling the membrane. And their handle is also this called Grease-Hopper handle. So it's not like, so it's like very ergonomic, 360 degrees, wherever you push on this handle, that opening and closing happens. And these are just a few other forceps, scissors, and stuff like that. But there are numerous forceps like this. This is a video that, why don't we do all these videos that I have here in the slide? If we have time, I can go back to my hard drive. Those are videos that were not compatible with my system, so and I couldn't convert them. So I'm going to show you a few lens implantation surgeries that I, as a retina doctor, do. That's why I thought maybe it's better for us to see a simple cataract surgery or a little bit more complex. So these I don't necessarily do these, but I've done before retina. I've done thousands of these surgeries, so I love it. It's a very easy and very satisfying surgery, and patients are very happy. So I still do these surgeries. But any ophthalmology, any eye doctor, almost any eye doctor can do these surgeries. So we are filling the eye. So this is filling the eye with jelly. Pupil is dilated. So lens, you remember. So if you, again, this is how I describe it to my patients. Lens is like an M&M candy. It has a colored shell and then chocolate inside. Chocolate inside is the cataract. The colored shell is what I'm removing now. That's the capsule. I'm creating an opening in the colored shell to allow me to remove the chocolate, which is the cataract inside. So, and it has to be a round circle like this, because if there's an edge to it or a tear to it, it can extend and violate, compromise the entire colored shell of this lens. So I removed that opening, and so the lens material or cortex and nucleus is now released. And this is aspiration, but it's not just aspiration. With ultrasound waves, we break these protein materials into tiny, just micron-sized pieces or particles or dusts like that.
It's sort of like jackhammering.
Almost, yeah, almost jackhammering. Yeah, that's a good way to describe it. And the reason for that is that this cataract is that chocolate is a very stiff and tough piece of a protein. We cannot just remove it or scoop it out or just aspirate it, unless we make a big incision, cut a big cut, and that's going to have its own problems with inducing astigmatism. Cornea is not even and stuff like that. So so I'm removing this, and these are just.
And just so the audience knows, you're removing the lens because it got so chocolate, it got so unclear that it's hard to see.
That's absolutely right.
I've got two of them myself, so.
Okay.
Yeah.
All right, so patients ask me, so when they ask information about the surgery, I say there are a lot of videos in YouTube, but I don't recommend them, but I recommend you to go and see them now. After surgery, of course, you're welcome to go and see. So I hope that these are not making cataract surgery scarier to you.
When I had mine done, which was...
Oh, you had done it done.
Yeah.
Okay. No,
a couple of years ago, we were doing some research with the surgeon, and we talked the whole time. He said, I'm doing this now, I'm doing that now, and it was great.
Yeah. So this is, as I said, very easy. It's very very demanding surgery from our side. But for a patient, it's super easy. So you see, I've almost removed all the cataract now. There are some pieces with a different type of aspiration tip. I'm going to aspirate those. Now you see that clear opening. Now this is the lens. So these lenses are foldable. So it's folded, and I'm going to inject it inside the eye. So inside the eye, they unfold. And I put that in the shell that holds the lens. So what is injected here in the eye is the lens. Now it's unfolding, as you see. Eye is filled with a different type of liquid, which is a gel with viscoelastic, so methylcellulose gel or hyaluronate gel. So I'm removing those with the aspiration port. And you see those two arms, those are two arms of the lens. So they are going to open up, and they are what are holding the lens in place. You see that lens is wiggly now, right? So as with water fluid current, it moves. But then when those arms open, they're going to hold things in place. They didn't open as I expected, just immediately. That's why I used a second instrument to release them. And then they are just like C-shaped arms.
They're sort of like outriggers that keep the lens centered.
Centered, and yeah, it's just not moving. All right, so like this. And this patient, 10 minutes, as soon as they come out of the room, life is changed for them. So they see everything, like very often patients say that, today one patient was saying that when I looked at my window outside, I said that, hey, I've never seen world like this, as clear and as bright.
Yeah, if I can add, so it sneaks up on you as you get older, and so you start seeing it, particularly driving at night, driving across campus, everybody's wearing black clothes, and all of a sudden you don't see them and all this stuff, and you don't do them both at the same time. Usually it's a week apart. So I remember driving to campus, and one eye was done, and usually I couldn't see what was on the sign above where the lights were. I couldn't read the road sign. And with one eye, I couldn't read it, and with the other eye, I could read three intersections down. That's a difference. It's great. Plus, then I don't have to wear glasses anymore.
Yeah. So these are all. It's nice. So this is a little bit complex cataract. So I wanted to show you this other medical device that we use. When I was getting my training, we didn't have this. So if a pupil doesn't dilate, it's hard to remove the cataract, right? So you saw that the pupil was wide open. So this is a Maleugian ring. It's not like a ring, but nevertheless, it's called ring. So it's a very cool idea, very smart idea. And Maleugian is a billionaire now, probably, so who designed this. So this is just recent, not too long ago. So you see this is like a spring that holds iris open. And then at the end, you're going to see how I remove it. So you see now, pupil is wide open. I'm going to do the same thing. So we will skip those. So cataract is being removed. Lens is being implanted. And now I remove. So you can just go here. Anyway, so I removed, so I released one of those loops from pupil margin, and I just rotate it out.
For that incision, you're going to suture.
No,
afterwards?
still no. It is no, it is same. So 2.4 millimeter They are self-sealed.
Wow.
Of course, we hydrate, so I inject fluid at the edge. I can show you, probably I have it here. But so to just cause a little bit of swelling in that tissue, and it just self-seals.
Wow. And do you do that Z cut?
No, we don't do it anymore because these are small
Wow.
incisions. And then since they are beveled, if we increase pressure inside the eye, the posterior lip pushes against the anterior lip and then closes. It's sort of self-sealed or just a closing mechanism. Okay, and checking to see if there's any leakage. There is no leakage. This is a sponge, like almost a paper type thing. They swell if there's water. So you saw the cataract is nice and easy, right? So 99% is like that. But sometimes if a patient has underlying problem, history of trauma, or capsule is not good, or the surgeon doesn't do it well, then capsule, that shell breaks and pieces of cataract falls into the vitreous. So then that's a big problem. So then someone like me, as a retina surgeon, we go and remove that type of the cataract from behind the eye, deep inside the vitreous ocean, and then place a different type of lens. I'm hoping that I have time to use that. I'm going to show you a few. These are just cool cases, and I've edited those, so these are go faster, hopefully. So these are, some of them are traumas. I want to give you enough time to read this. So hammering metal on metal, never do it, okay? And we were seeing a lot of these during COVID. People are doing all these sort of do-it-yourself projects at home. So I did a study with one of my students, medical student. We looked at the rate of trauma before COVID, during COVID, and after COVID. And there was a huge spike in eye traumas during COVID. So high velocity projectile. It went into the eye, but it was so high speed that it passed through the eye and went to the other side. So this is in CT scan. You see that this is behind the eyeball here, for example. And everything looks nice in the front, right? It's just a little bit of redness. So that's the entrance site I'm suturing. So this is a different type of surgery. We do scalar buckling. So I did that. So that's the. It didn't go outside the eye. So that's another patient. But this was. That's almost 5 millimeter, 4 millimeter, 5. That's huge for the eye. So that's the impact site. I'm doing laser around it. I'm sorry, what?
I was going to ask, on suturings, do you get stigmatisms?
No, since they are behind the cornea, they don't cause astigmatism a lot. So that's sclera. The white part of the eye doesn't induce astigmatism. But look, after 6 months, he has a 20/20 vision. And now it is almost 2 years after his surgery. He's very young. This is also a nice case of, so this is even worse. So he was cutting, wood pallets, right? Pallet you call, so those pallets, at home just to make something, a chair or something. But then one of those old rusty nails went back into the eye, and this is the tip of the nail. Oh, Lord. But you see that CT scan, the nail goes all the way to the back. And this is the nail that got removed. This is my record. So this is the largest foreign body. But then, let me stop here. So when we remove this, if I do surgery, so if I don't do surgery, there is an opening in the back part of the eye that, blood is coming in the eye, blood is inside the eye, patient cannot see. If I do immediate surgery, so I can suture the front entrance side, but the back part I cannot suture. We cannot suture it, so we cannot go all the way to the back to suture it. So in these situations, we wait for 10, 12 days for the back exit side to just scar on its own, and then we go and repair. So that's why I waited for a few days. Oh, man. So eye is filled with blood, but retina is luckily not detached. So this is we went back and repaired the entrance side better. But this is, you see, eye is filled with blood. And that gives you a better idea of what vitrectomy does, how it removes vitreous. This is the exit side. So if we don't do anything, if we don't remove those scars and don't trim them, they pull, they contract and pull on retina. I removed those, did laser around it, do the buccal. Day 1, 24 division. That's the exit side. And in 1 month, he had a good vision. In 6 months, he's, I think, now better than that. So I'm gonna skip this. This is just, this lady came from North Dakota, got hit in the eye with golf ball. But you see, everything is, there's nothing inside the eye, but eye is ruptured and there's blood everywhere. So this is retina that is detached. Under the retina, I'm removing blood. I don't want to go into a lot of details why we do this. But anyway, so this is a sort of a cool surgical technique. I prepared this for other teaching purposes, but I'm just showing you this. So this lady had a 20, not 20, but count finger vision. So NLP vision, no light perception, but eventually she ended up with some levels of vision because of severe damage that she had in the eye. This patient had the lens surgery years ago, but then had a trauma. And then as we age, those structures that hold the lens in place, they come loose. So the lens fall to the back with everything. So lens is falling to the back. But this is also, this video, I think you want a smaller word, but this is a cool technique also. I'm holding the lens. So what we do normally, we remove the lens and put a new lens inside. But then this is a PMMA lens, Professor Erdmann. This is not one of those foldable ones. Oh, okay. To remove this, I have to make a big cut in the eye. Yeah. But then this lens was in a way that I was able to fixate the lens inside the eye. So I'm hoping that, so I'm just passing suture through lenses haptics. But to pass suture, of course, I don't have a good, huge needle like that. I put another needle and guide my other needle through that. So one arm of the suture goes under the haptic. The other arm now goes above the haptic, just holds it in place.
So this takes a custom strategy.
Yes, these are so we think about these surgeries the night before. I sometimes draw my strategy, what I do, what I'm going to do step by step. This is what I'm going to do. This is what I'm going to, from what spot I'm going to go. And this is probably one of those. This is also, so that this, that patient is also very, so this is also fairly young patient. One eye had detached, so lens subluxation, got surgery in Moorfield, London. But then this other eye happened here, and I did it, and this eye is better than London eye. This is a different type of lens, as you see. This is plate haptic lens. Again, since it had 2 holes, I said, there is an opportunity for us to, instead of removing the lens, we can use the same lens to in the eye. It's always better because then, as I said, we don't need to cut a big cut to remove the lens. But then it's a little bit challenging, right? So to hold the lens in place, to clean it, as you see, to pass a suture through the hole.
In that case, if you had to cut the eye, that would be a stigmatism.
A huge astigmatism, yes.
Yeah.
And it can never heal as, these small incision. So now again...
Maybe you can define stigmatism for the folks,
Yes.
what that means. Can you define stigmatism?
Oh, okay, I'm sorry, I thought you were talking. Astigmatism is, so eye surface, cornea is like a sphere, like in ideal world. It's like a cut or cross-section through, a sphere. But, if we put a suture in one side, then it's not like a sphere. It's like a football, like cut through football. One meridian is more steep than the other meridian. So it's like oblong type of a cut from a football. And then we have to add corrective lenses to compensate for that difference in curvature. But of course, with these sutures, then that astigmatism many of us can have, and I also have. But this is just a quarter of a unit, half a unit. These can have like 5 units of astigmatism, 8 units of astigmatism. They cannot tolerate the glasses. Okay, so you saw how we did it, and now we are removing the infusion and placing a suture. You see, I promised that I'm going to show you blood, and I didn't.
I have a question.
Yes.
The lady who had the golf ball trauma, you said her retina was partially detached. Were you able to reattach that?
Yes, so not partially, completely detached. Yes. Otherwise, she cannot see. And then not just not being able to see, if retina is not detached, it's like, so everything just collapses. So retina keeps things, it doesn't have that structural, in some ways, it gives structural stability to the eye.
So you said she got hurt in North Dakota. Do you have a time frame of if retina detaches at 10 o'clock in the morning, how long do you have before it's a lost case?
We do, so the rule of thumb is as soon as possible. But of course, not all patients can come as soon as possible. So, as soon as possible. So that's the short answer. But even if patient comes after 10 days, we operate because we can do a lot for those. The outcome might not be as good as when they come, but immediately. But regardless, they can get improvement. Because if we don't, then that's almost the end of it. That's the end of it. So this is the bloody part. Okay, I was told that I can skip. Okay. It's not skipping. Anyways, so we place the buccal from outside, and this is sort of to bring outside wall, a little bit indent the outside wall to help to attach retina to its place.
Hi, so quick question. What type of operation would this be for in terms of like needing this many like hooks in the eye for?
I'm sorry, what was the question?
What type of operation was being performed here for?
Here, so this patient has retina detachment. Is that your question? So this is retina detachment, but the surgery here, this is called scleral buckling. We buckle the sclera, the white part of the eye, to indent it. And then I'm going to do vitrectomy also. So it's the same surgery, but you see, vitrectomy is just a general, almost term, a versatile surgery that through that you can access to retina to do different types of diseases. Sure. So now buccal part is done. Oh no, I skipped back to the center, to the beginning. Okay, yeah, so this is it. So for the buccal part. So let me go back. Now, so when we do the surgery, light sources in the eye, then to have a better contrast, we darken the room. So everything should be dark. So that's why you're seeing here. So these videos are not edited, so now we are maybe waiting for a tool, or I'm talking, or just talking with anesthesia. Patient is not stable. We are waiting for patient to stabilize. So this is the vitrectomy part, and in this corner you see that retina is detached. And retina detached all the way to the nerve, but since these are shallow fluid, it's not as obvious as here. So you see that retina is detached.
We have about 15 minutes.
15 minutes, yeah. I think we have just a few more videos to look. So peripheral retinal, right behind the iris, we indent it. You see that there is an indentation to be able to clean the vitreous from it. Those white like snow, you see, it's a medicine, triamcinolone, that attaches, it has crystals that attaches to vitreous. So as you see, vitreous, if it is clear, it cannot be seen. But with triamcinolone crystals attaches to it, and we visualize, helps us visualize the vitreous. But you see also there is a white deposits. So this helped us to know that there is remnants of vitreous on retina surface, and I peeled those in this next video, as you'll see, so to prevent membrane formation in future. Okay, now. Just continuing that cleaning. It is again, very delicate part because that retina is mobile, moving, and we don't want to take a bite from retina. So he already has a tear or a hole in retina, so we don't want to create more holes. And we are working very close, super close, with the aspiration that can pull this delicate tissue into the mouth of a vitrector. So this is, again, with the forceps, I'm grabbing those remnants of vitreous and peeling. Yes?
Can you not put the retina back down until the vitreous is removed? Or why are you doing it in that order, I guess?
This is also a good question. Because vitreous contracts. So when it is violated, when it's not violated, it's like a jelly inside the eye, just behaving normally. But when, as I said, if it doesn't behave normal, it could go really bad. It's like a scar that contracts and pulls retina and detaches. Sure, and it doesn't.
So it's kind of the cause, is what you're saying.
Exactly.
Okay.
Exactly.
Thank you.
So even retina detachment and tears are coming from vitreous. So vitreous changes, and during that change, pulls on retina and creates a hole. So these are more like now So again, there's a lot into it, but to drain the fluid from the retina. Now you see that retina, so this is the hole patient had in this part. That's the hole patient had. But then for us to drain the fluid, we fill the eye with air. But if we fill the eye with air, patient is sleeping this way. It's going to push fluid all the way to the back. There's no drainage side. So we create a intentional hole in retina, in the dependent part of retina, and aspirate fluid from that. So that's what I'm doing now. And then, of course, we do laser around it. So while this is exciting for me as a doctor who was treating these diseases, and probably gross and scary for you, but I want you to think about all these tools and devices that I'm using. Every single time, even air. Air is I'm using, but the machine that pushes air inside the eye with the pressure that I want, so and holds this steady, stable, in a set pressure.
Excuse me, I just have a question. I'm sure you probably already briefly mentioned this, but I just wanted clarification on the purpose of the laser here in these operations.
This is a good question. These are just like given for me. But yeah, I should explain this. So with the laser, we, in essence, burning retina. So we are burning retina to initiate a localized, controlled scar around the tear. So then sort of welding retina around the tear, so fluid cannot pass through.
So it's like a TIG weld, right?
Exactly, so yeah.
Yeah.
Do you have a problem with burn? Do you have any challenges with burn or particles coming off of the laser as you're doing that? Have you ever seen that?
Challenges with burn?
Charring or, yes.
Charring? No, so of course, we adjust the power. So the power, duration, so the wavelength that we use, these are all adjustable and settable, or we can choose from. So based on laser tissue interaction to get that safe effect that.
So there's a very specific burn depth you're targeting then as you're
exactly
ablating.
exactly.
Okay.
So if I do my maximum laser power, I'm gonna burn or pop, or my blood vessels may pop and I can have a lot of bleeding inside the eye. So doing laser around the tear, and also I'm gonna do laser around the buccal.
I have another question.
Yes.
So if the retina detaches because of lattice degeneration, or you already have, basically, is a retina always a fixed size? So if you lose some of it, you're in trouble and you can't reattach it? Or is it no matter, and if you lose some in the process of the tear, you can still, because with the lattice, my understanding is that there's a weakness, so it's not really very usable in one sense.
These are good points. So retina, again, in our world, visual field, so a central part is responsible for here. This peripheral part, lattice or tear part, is responsible to here. So even if we do laser and we kill part of it or we lose part of it for tear, so our visual field gets a little bit smaller, but again, not much noticeable. So, but in terms of size, that's also the big consideration for us. Sometimes in long-standing retina detachments, like what you mentioned, retina gets intrinsic shortening. So no matter what we do, then retina doesn't fall back on underlying layer. Then we cut retina from part, so we release retina from one end of attachment, right? Because from the other end is optic nerve that we cannot cut, of course. But then the other end, the front part of attachment, we release it so retina falls back to its place. Does that answer your question?
Yes, thank you.
All right. All right.
Question.
Yes?
I was wondering if you could touch on the devices that you use in these videos, if there's any ways that you wish they were improved.
Yeah. So let's go on this. So a lot of things, right? So a lot of things in different ways. For example, there are eyeballs that are high myopic, just longer than normal eyeball. Then our tools are not long enough to reach, right? Then you can say, okay, we can just make it longer, but then these are 25 gauge. When we make it longer, they are gonna bend and just flex, and it's not gonna have the same. So things that, for example, things that can improve our probes in a way that we can operate on longer eyes, for example. Better control on fluidics and pressures on the eye. So fairly recent developments, illumination from outside the eye. So depression you saw, we were depressing, but if our depressor has a light source, we can illuminate from inside, illuminate from outside, and that contrast helps us to see things better. This is a patient who had surgery this is not the one that I wanted to show. Maybe I don't have that here. Anyways, let's do this. All right, this is a patient who had surgery before. There was silicone oil in the eye. Lens was removed. This is a retina detachment. Retina was, just crumbled and a lot of scars. So I've fixed those. I've removed the lens. So in the beginning, before we know that retina is attached, sometimes we don't place a lens. So this patient doesn't have a lens, but has a silicone oil bubble that holds retina in its place. So now after a few months, retina is in place. Scar tissue hasn't pulled retina and detached it again, so we don't have a recurrent surgery. I'm going back to remove the oil and place a lens inside the eye. So first I'm measuring where I'm gonna place the lens before I do my other stuff. So infusions are being placed, infusion lines and other trocars are being placed. As we are aspirating the oil from the eye, replacing it with saline. These are bubbles of oil.
Are the trocars just friction fit? Or is there something inside that keeps the trocar in place?
They are friction fit.
Okay.
They are friction fit. So with older trocars, 20 gauge, they are huge. So we used to suture them.
Yeah.
But they're just snug in place. Mm. Sometimes they move, and then we have to put them back in place. So now we have removed the oil. Everything looks good. So there's a bubble in front part of the eye that is blocking my view. So I'm removing that. Well, I don't have the lens part. Oh, this is the part. Okay, so oil is removed. The retina was there were a scar tissue on the retina, so I removed those also. But you see, again, I'm placing a needle, passing it through those marks that I placed, 2.5 millimeter from the cornea. This is a very cool surgery, and that got introduced recently. Actually, I have a video doing this in 2008 and 9 in Tehran. I did similar surgeries, presented in a European conference also, the video. But at that time, I didn't have much vision to know that these are super innovative things. But then people learned to do these, and Yamani from Japan described it in 2015 or 16, and people started to do this. So this patient doesn't have, so we remove the oil through those holes, but doesn't have a cut to place the lens. So I'm making that cut. So I have to skip because now we are only 1 minute left. Is that okay if we go a few minutes over?
Sure.
Doctor? All right, so this is the lens. This is a different type of lens, as you see. So there is a lens, but haptics are, so the lens material is acrylic, but the haptics are silicone polymers. So the lens is inside the eye, but how we can fixate it to the eye wall, because now we don't have that structure that holds the lens. Capsule is gone.
Capsule plan.
That colored shell is gone. What was holding colored shell in place is gone. So I'm grabbing it. I have the needle. You see the tip of the needle? I put it in the needle. And that's it. So that's one needle, one haptic. So this is now the second haptic. And trust me, it's really hard it's not hard, but it just needs practice. So for our trainees, fellows to do this, it takes many, many surgeries to attempt to just find a hole. It just seems obvious that there's a needle there, but just aiming it and just making it inside. All right, so look how we fix it, and this is the cool part of it. So we didn't know this at that time in Tehran when I was doing this, but that's the cool part that Yamani from Japan described. So the haptic came out, but with the high temp cutter, we create a flange on tip of. So I'm not touching it, but just with the, not touching, just getting close to the flange. But you see that club or flange on top of, at the tip of the lens? That's what's going to hold the lens in place. So one haptic is fixated.
The haptic almost looks like a suture in this case.
Yes,
Yeah.
so this is not suture, but
More like a suture than...
more like suture. But I went through, I didn't go directly in. I went through a 2 millimeter tunnel within the thickness of sclera. So I didn't go directly in. I went oblong within the thickness, so that haptic, that flange, cannot pass through all those scleral collagen fibers. So this is the other eye. This is my assistant, or maybe this is my fellow is doing this. I am drying out, and we make. You see, that little club at the end of the.
What's a typical outcome for success rate, for instance?
100%. It's hard to say 100%, but we aim for 100%, and we land there very, very closely.
What type of complications are typical?
So this lens cannot be fixated properly. So the following day, and I've had one patient. The following day, I saw that lens haptic just released, and lens is now upside that. We went back and fixated it again. During the surgery, if something happens to retina, so those needles, if someone is not careful, you can hit the retina, cause retina detachment. This is a complication that is more commonly seen is hemorrhage in the eye. So when we go in, we can have a little bit of hemorrhage from going inside the eye, but we don't do anything. We just wait for a week or so. It resolves. If we are not careful, we can cause damage to cornea. When I place the lens, my tools cannot touch the cornea. I can cause damage to iris. So many things can happen. That's why this is not an easy surgery. This is one of the trickiest surgeries. And even within retina, not many people do it. Probably just 1/5 of retina surgeons, or just a handful, just a few in the state or in our city can do this. It's definitely not more difficult than other things that we do, but it just has a learning curve. You just need to do it enough time with someone sitting next to you to get good at it. All right, now I'm cleaning the anterior chamber behind the lens. It's called anterior chamber. We fill it with a gel type of device or gel type of liquid to protect the cornea. All right, that was it. So,
Well, do we have any last-minute questions? Yes, we have one in the back.
I was just curious as far as the lenses that you're putting in. Who do you procure these lenses from, or who makes them? And do you have a preference, or?
That's a huge industry on its own. And just imagine, I don't know how many, maybe 10, 15 million cataract surgeries are done every year in the US. Hundreds of millions of cataracts are done in the world. And these lenses are it's got 150, 200, sometimes 700, 800,000 something dollars. It's a huge industry. So based on some measurements, we know what power of lens we place. And then there are a few lenses that we prefer. For example, this lens, this last lens, this is a Zeiss's CT Lucia 602 lens. Its material, haptics material, is in a way that is very conducive or suitable for this type of surgery. Others, the haptic may bend or, just has a kink, and then we cannot do anything. But that's a huge industry on its own. Lens is just... Now we have light adjustable lenses. And this is new. I haven't done it. So this is just, and they are like a couple of $1,000s. You implant a lens in the eye, and then the following day, you measure how much of refraction they have. Let's say they have -1 refraction. And then with the light, you adjust the lens's curvature. And that's amazing. To correct that -1, and then patient doesn't have any refraction. These are amazing things.
Yeah, thanks so much. This is just absolutely amazing. Do you know if robotic assists have been explored for this area?
Robotics? So robotic surgeries has been explored. We are not as much advanced probably compared to other fields. For example, in laparoscopic surgeries, urology surgeries, they have done robotics. But in the ophthalmology, I know that there are work being done, but not much. There are so much, none of these are straightforward. A lot of, so many decision making go into effect every single second you do. I'm not sure if how it can work, but probably can work. Everything can be solved with technology. But I'm not aware of that. robotics in a way that remote operated, could be a cool thing, right? So we are with Sarah, we are working on a remote operated camera. So, but surgery, can be done probably.
Okay, yeah, going off of that, like, note on technology, I was wondering if you particularly, not going into hyper-specifics, had something in mind that, like, technology-wise, that would make these procedures easier moving forward? Like, what sort of progressions you could possibly see, like, making these more efficient or have a higher success rate, for example?
For example, these machines are like a constellation in a scale of $120,000. So these are very expensive devices, and they are for operating room. There are procedures that we can do in the office, but we don't have an office-based machine. So maybe, and not that we don't have, not that they don't think about it. Of course, they think, these billion-dollar companies, but it's not met, or we probably don't have a good solution for that. But I was just talking with you that I have some ideas we can explore those how we can. So for example, that's one example. Making it cheaper, making it compact, making it. Now I'm doing. We are building a program, retina training program in Honduras. I went to Honduras last year multiple times to do some of these surgeries there. But then in these these parts of the world, if constellation breaks, it's like 6 months of no surgery, because before you find someone to come and fix it. But then Ortli from Switzerland has a machine, vitrectomy machine, that is like a suitcase. You can move it, you can move from between centers to center, it is easily fixable. These packs that we use, these are $400. So if you can use reusable or just cheaper, just change it in a way that it doesn't cost that much. So these are all, every single step or every single piece. So you can think of so many changes in innovation that you can make to make things better, accessible, more affordable. Things like that.
So I want to say you've been a super audience. Lots of great questions, everybody. We need the questions, and I think it's been a wonderful session, and really want to thank you, Dr. Nazari, for doing this. So.
Absolutely. Thank you so much. Great questions. Thank you, Bob.